Thank you, Pedro. Good afternoon, everyone. Thank you for having me here today, and welcome to the IHI BMJ International Forum. I would have, of course, prepared to be addressing you in person today, but I'm so grateful to every one of you for your commitment to quality and to health during these times of great need, and indeed of great optimism in so many corners of our world. I had an old professor and mentor once tell me that you should always have an agenda slide in a talk. I faithfully kept to that advice over the years, so here indeed is my agenda for our time together. I want to tell you two stories that are about where healthcare is going today and the choices ahead of us. I want to share a few ideas about what a better health creating system might look like, but then focus on what I think is still holding us back. Because none of those ideas is new, but something is still missing. Okay, let's start with a story. On August 6, 1945, at 8:15 a.m. local time, as the Japanese were waking up, American bomber jets flew over Hiroshima, Japan, and one of them dropped an atomic bomb that caused 80,000 instantaneous deaths and 60,000 more in the minutes that followed. This was the single bloodiest moment in the bloodiest war in all of human history. Japan surrendered just 9 days later. In the early 1950s, it was impossible to see how Japan could rise from the ashes of the deadliest and most devastating war in history to become the third biggest economy in the world, as it is indeed today. But that is exactly what happened. In the years after World War II, the Japanese economy lay in ruin. Supply chains had been crippled, and the consumer demand simply didn't exist. Back then, the Japanese automotive industry was known mainly for their habit of copying designs from other manufacturers. Toyota's first passenger car was a blatant copy of a Chevy design, and this World War II era truck, the Model KC, was made from spare parts. Its cabin replaced with wood panels, and the number of headlamps reduced to just one because of supply scarcity in Japan. Toyota nearly went bankrupt in 1949, and in 1950, its production capacity was limited to just 300 vehicles. By comparison, US automakers in this period, in the same year, made over 7 million cars. And yet, in that very same period of time, in the early 1950s, Japanese manufacturers were laying the groundwork for what would become their salvation. Japanese automakers faced a choice. They could cut back, cut corners, reduce costs, and produce cheap, low-quality cars that might create a market, or they could try to beat out the German and US competition by creating cars that would be more reliable and higher quality than the best cars on the global market. Many of you know exactly what happened next. W. Edwards Deming, a little-known statistician, had been in Japan helping the US occupying forces conduct a census. The Japanese had learned that Deming had some radical ideas about quality. In particular, the idea that by focusing on reducing variation, you could both improve quality and simultaneously reduce cost. Deming's ideas transformed the Japanese approach to car making, focusing them on producing highly reliable vehicles that earned a reputation for almost never breaking down or requiring repairs. By 1975, just 25 years after Deming's introduction to Toyota, it would become the most imported brand in the United States. In 2009, Toyota ended General Motors' 77-year run and became the largest car maker in the world. The lessons and parallels here are perhaps obvious. We have been living through and continue to live through devastation in healthcare. Our hospitals overwhelmed, our staff suffering traumatic stress, our economies suffering tremendously, the public anxious about yet another wave. Many parts of the world are still in the throes of this harrowing pandemic and can't see the end just yet. But we can see the key questions and choices that all of us must be forced to contemplate. How will we emerge from this? How will we be different? Will we turn to short-term thinking that will compel us to choose austerity, cost-cutting, and making cheap, low-quality care? Or will we have the imagination and foresight of last century's Japanese industrialists and once again turn to quality as our solution, both to better care and lower cost? Okay, my second story for you. This is a photo of the James River and a place called Tobacco Row in Richmond, Virginia, where a part of my family is from. Richmond was once the epicenter of the tobacco industry in the United States, the heartland of cigarette manufacturing. Tobacco was grown in the fertile soils of Virginia, upriver from Richmond, and floated down on this James River to these buildings in the heart of the city, where the tobacco leaves were unloaded, processed, and then rolled into Marlboros, Camels, and Lucky Strike cigarettes. Even today, you can still almost smell the musky scent of tobacco leaves when you walk around these buildings. And Richmond, because it loves its graffiti, has kept all of the logos of the old tobacco companies painted on these buildings. In its heyday, over half of all cigarettes bought and sold in the US were made in these buildings on Tobacco Row. By the mid-1970s, so much of the local economy was based on tobacco that the newspapers in Richmond called the city Tobacco Town, USA. They must have felt like these factories would never go away, that they were permanent features of the local economy, and that they could never be anything but cigarette rolling facilities. But then everything changed. Smoking rates started to drop, regulation by the US government increased, and a major lawsuit forced these cigarette manufacturers to pay hefty annual fines because they had been lying about the health consequences of their products. In just a few short years, these buildings were vacated and have now been converted into luxury loft condominiums and fancy restaurants with only the old logos on the walls to show of their tobacco past. I tell you this story because in the photo you will see another building in the back left, a high-rise, drab-looking structure. It looks like it was probably built in the 1960s or 70s. You know what that building is? It's one of the towers of the local teaching hospital. It has the requisite helipad at the top with multiple floors designated to ICU care and surgical theaters and general medical and surgical wards. And every time I see this picture, I can't help but make the comparison between that tower and the tobacco mills in the foreground. Today, the ICU tower and the dozens of other hospital buildings on that campus feel like permanent fixtures of the current economic landscape. The system's 24,000 employees make it the largest employer in Richmond, just as tobacco once was. But the same self-assured hubris that was once the undoing of big tobacco may well be coming for the hospitals of our world. Could the hospital's days, at least as we have presently understood them, be numbered? Or can they reinvent themselves fast enough to avoid going the way of the tobacco mills just down the hill? The modern hospital was conceived and refined over 300 years ago during the Enlightenment age, a time when the goal was to cure, when we mainly died of traumatic injury and infectious disease, when patients were the objects of care, and when technologies that could improve care were not wearable on our wrists or tucked in our pockets. Hospitals were and are costly and challenging to operate. Most of those in current use were built decades ago, and maintaining and managing them has become notoriously difficult. And today, we are becoming healthier. The last year notwithstanding, health technologies, breakthroughs in surgical technique, novel diagnostics, therapeutics, and even preventative technologies like vaccines have made it possible to live longer, healthier, and less dependent on hospital care. Virtual care has made it possible to receive much of what we need remotely in our homes. Surgical care has begun to move out of the hospitals to ambulatory day surgery centers. Mobile X-ray and lab technicians can now do much of what we needed to do in hospital in the community. And video conferencing technologies like this one has democratized knowledge and made subspecialty care available in our community doctors' clinics. In the US, the CEO of a very large health system here, a system of 23 hospitals, told me that for the first time in 2019, hospitals were the minority contributor to his bottom line. Revenues from all of the other businesses he was having to operate, the R&D enterprise, the spin-off companies from that R&D, the data services they were selling, ambulatory care services, retail clinics, their investment portfolio, those companies and subsidiary revenue streams added together had, for the first time, outpaced the hospital revenue of this hospital-based health system. The shift away from hospitals is already happening, and it will, in my view, accelerate. Technologies will get better. We will do more outside of hospitals. Our insurers and payers will not want to pay the costly overhead of those hospitals. And frankly, none of us really wants to go to a hospital if we can find a way to avoid it. So when will we declare the way we have been doing it and the way that it's always been done, needing a fundamental rethink? I believe we actually already know a lot about how to build a different health system, one that doesn't just aim for more healthcare, but instead tries to produce better health, one that names and addresses medical needs, health-related social needs, and their causes, the social determinants of health. You've heard a lot of these ideas before, and they are baked into designs that have been spoken about for many years. Everyone's formula is slightly different, but this moment that we are coming through has made a few of these ideas paramount as we consider the future of the hospital. The key design ideas are all variants of the following. I'll summarize them before turning briefly to what I think is the real challenge ahead of us. Supercharging primary care, investing in full integration across the real care continuum, centering the patient, realizing the true potential of digital health, and creating real health equity. The first idea is to create supercharged and vastly more enabled primary care. Primary care for a long time has been whittled away by specialty care and hospital care. In my country, primary care visits constitute 35% of all visits to healthcare, but they receive less than 5% of our total national health spend. Inpatient care, on the other hand, is used by only 3% of the population, but receives more than 26% of the total spending. The resources here are misaligned. Any real redesign will start with a radically different and much better financed primary care system. This past year, IHI partnered with Project ECHO to bring COVID specialty knowledge to over 9,000 care locations across the United States. Project ECHO is a program led by this gentleman, Dr. Sanjeev Arora, a liver doctor at the University of New Mexico. Sanjeev created Project ECHO because one of his first patients was a middle-aged woman with hepatitis C with several school-aged children. She had waited 8 months and driven over 300 miles to see him. And by the time of their appointment, her hepatitis C had progressed to advanced cirrhosis, and a very treatable condition had become untreatable. She died just a few months later, leaving behind her 2 children. Deeply affected by this tragedy, Sanjeev began teaching the primary care doctors in this woman's town 300 miles away from him about hepatitis C. He coached them via video conferencing platforms like the one we're on today to identify the disease earlier and begin treatment under his tutelage in their clinics close to these patients' homes. This shortened the time to treatment and reduced waiting times throughout the system. And the results were stunning. Virologic response rates in primary care clinics coached by Sanjeev and his team were the same as the treatment success rates in his university clinic in Albuquerque. Sanjeev had found a way to supercharge primary care, and in so doing, he had reduced waiting times, improved the patient's outcomes, and substantially reducing costly delays and complications. This concept has now been extended to over 100 clinical conditions and to behavioral health integration across thousands of clinical settings all over the world. The second key design idea is to integrate across the real care continuum. This idea is a combination, actually, of 2 concepts that you have likely heard before. First, the idea of integration. We talk about horizontal integration being where hospitals join up with other hospitals, and vertical integration being where hospitals join up with ambulatory care clinics and sometimes care homes or post-acute care settings. But real integration True integration would go well beyond either of these into the community care organizations that are trying to create health. Only when health systems work in real partnership with social care systems in the community will we create health and stop creating more health care. This is absolutely what we need. And we need it across the real care continuum, not the formal care continuum that exists when people first meet us in the emergency department or the clinic. But health begins, as my friend and IHI Senior Fellow Nigel Christ describes it, in the home. By the time we meet patients, and by the time we have met our patients in our clinics and in our A&Es, we have already foreclosed on many paths to health. We have lost many opportunities to heal and to restore health. By the time we are in formal healthcare settings, especially if we are of older age or if we suffer from multiple comorbidities, we look like nails to the incessant hammers of healthcare. The real continuum begins in whatever location we call home, and with whomever we love and whomever loves us. That is the merger we need from health and care. Now more than ever, we need healthcare to meet our families, integrate into our communities, and build networks with those that feed our souls. Let's talk for a minute about centering the person that we have forever called the patient. This is a quote from Erin Moore, the mother of 5 children, one of whom is affected by cystic fibrosis. This quote has always struck me from the moment I encountered it a few years ago. Erin writes, "It would be relevant to me if you join me in what I'm doing, instead of trying to engage me in what you're doing." Maureen Bizignano, IHI's former CEO, has made a similar point from this virtual stage. She asked us all to stop asking our patients, "What's the matter with you?" and start asking instead, "What truly matters to you?" A health-creating system will demand a massive unleashing of more activated and empowered patients and families with a transformed sense of ownership of their health and the agency to massively improve it. We should not be surprised by our patients' desire to co-produce care. We should expect and welcome it. And while our technical expertise as clinicians is always going to be important, the most essential contributor to any health outcome will always be the person whose health is at stake or someone who loves them. The sooner we build formal pathways to unleashing that intrinsic motivation, the sooner we build a health-creating system that we all need. Technologies will enable these parallel revolutions in patient activation, true integration, and supercharged primary care. And yet, we are too often blinded by the dazzling possibilities of technology, only to be disappointed as it falls short of realizing its true value. Yes, the pandemic has caused an unbelievable upswing in telehealth and other forms of virtual care that have just exploded in recent times. But the promise of digital transformation could realize much, much deeper effects. Consider for a moment how good AI or artificial intelligence guided diagnosis and triage have become. In a recent study of 500 consecutive urgent care patients, when compared to physicians' final diagnosis and treatment plans, artificial intelligence gets the same answer 90 to 92% of the time. AI-guided algorithms have been trained on millions of chest x-rays like the ones you see here and can identify notoriously difficult to find tuberculosis with 95% accuracy in the remotest and most hard-to-reach corners of our world. And what's more, miniaturization and task shifting to advanced practice providers can allow for routine hospitalization to take place at home, with patients receiving essentially the same care they would get in the hospital for common conditions like pneumonia, cellulitis, and urinary tract infections, IV therapy, labs, x-rays, from a fully mobile service, and subspecialty clinical consultation, if needed, from a remote command center. And all of this achievable in the relative safety and comfort of your home. But the promise of these incredibly exciting digital technologies, these digital therapeutics, diagnostics, and monitoring systems, they are all held hostage, just as more conventional medications have been for decades, to the unreliable and unsafe systems required to implement them. Years ago, IHI was started, in effect, to work on exactly those processes, to take the fruits of clinical science, medicines, diagnostics, vaccines, and more reliably deliver them to patients to create lasting health effects. In my view, it is time for a complementary agenda. Quality, safety, and reliability sciences must now be applied to improve the delivery of proven digital therapeutics and diagnostics. Just as we created reliable workflows that delivered antibiotics that could prevent sepsis death, so too must we now create workflows that will reliably leverage new data sources and technologies to connect patients to providers and anticipate errors or rapid deterioration before they happen. Digital health will change healthcare, just as antibiotics once did. But neither of them will achieve the kind of impact we need without improvement methods that make them safe and make them reliable. My last idea: there is no quality without equity. 20 years ago, the Institute of Medicine here in the US invited us to consider 6 new aims for better healthcare: safety, effectiveness, efficiency, patient-centeredness, timeliness, and indeed equity. 2 decades later, we have a lot of room to improve in all of these dimensions, but none more so than the last of these. Equity, or equality as it is sometimes known. There can be no quality health system that excludes many from the benefits of that system. There is no health creating system without equity. I've been studying the work of Professor John A. Powell, a professor of law and ethnic studies at the University of California at Berkeley, for some time now. Powell articulated the framework of what is now known as targeted universalism. His theory is one that suggests that the better and perhaps more efficient path to universally held societal goals may be through the use of targeted strategies that help advantage those who have been systematically disadvantaged. I think that this theory will help create far more health, far faster, and in a far more distributed way than anything that we have currently imagined. Consider for a moment the successes of our colleagues at South Central Foundation in the US state of Alaska. Our colleagues there began their COVID vaccination efforts by focusing on the most under-resourced Native Alaskan and American Indian populations. We all sought herd immunity. We all still do seek herd immunity, a universal goal. But the strategy of our colleagues at South Central led with an inclusive approach to reach those that were the hardest to reach first. Their strategy quickly led, for a time, to the highest per capita vaccination rate in the country. If we focus on the most marginalized, it turns out we can actually get to universal goals faster and even more effectively than if we do not. I could go on for a while about this theme, but for now, let me offer that every one of us listening to this conference today can go back to our institutions and ask this one simple question as we go about our work. Is equity an explicit strategic priority for my health system? If it isn't, it should be, because without your voice, it won't be. So those are some of the ideas for a system that creates more health. Supercharge primary care, integrate all the way into the community, center the person, unlock digital health's vast potential, and make equity a strategic priority. But many before me have stood on this stage and given you some version of that recipe. And honestly, you know many of these ideas already. They are baked into the integrated care systems in England and the regional councils in Sweden and many of the advanced care notions we have heard about in other nations around the world. So what exactly is missing? Many years ago, Dr. Tom Nolan from the Associates in Process Improvement described the 3 central elements of how to change almost anything: create will, have better ideas, and never fail at execution. Well, we have no shortage of ideas. You have no shortage of ideas. We will trade them in this virtual meeting over the next few days actively. And indeed, we have many of the elements of how to execute. But I believe we must now talk together seriously about how we will create and harness the will we need to really change healthcare, to reach past the social determinants of health to the underlying structural determinants of health, the true causes of the causes. And to that end, I want to tell you one last story. This is a story from Health Partners, a system of 1.8 million members and 8 hospitals headquartered in Minneapolis, Minnesota. It's a medium-sized system in a medium-sized city in the middle of America. Minneapolis, like much of the world, has gone through 3 successive waves of coronavirus, but it had an additional layer. Minneapolis was the home of George Floyd. And as all of you likely know, last year, right around this time, May 25th it was, George Floyd, a Black man, was murdered by police officers in broad daylight, setting off a global racial reckoning that has rippled around the world. In Minneapolis, the city was gripped by outrage, frustration, and unrest. And so was Health Partners, whose hospitals cared for many in the community and in law enforcement alike. Health Partners itself was consumed, staff and patients, at the intersection of 2 twin crises, pandemics of COVID and racism. In recent conversations, leaders at Health Partners described their efforts to tackle these challenges as it charted what may be the 4 active ingredients to harnessing the will for real and lasting change. The first ingredient they found was radical prioritization. COVID and racism pushed for a moment everything else aside. The list of hundreds of improvement projects and initiatives were put on hold, and everything, at least for a period of time, became about these 2 crises, and everyone was aligned and all in to help address these issues. To build will, we need to focus our attention on single, much more ambitious goals. Number 2 was radical transparency. During the pandemic, many reported that they were sharing information that might not have been shared before in new ways. In Southwest Ohio, a group of healthcare organizations created a common data system to track and follow COVID patients. Housing authorities and public safety officials shared data with healthcare organizations to support contact tracing. We've seen in this era a complete rethink on data transparency. Shared data will create a common vocabulary for the system change that we need. Number 3 was a radical form of collaboration. IHI has long had a philosophy of all teach, all learn, an appreciation that everyone has something to teach and everyone has something to learn. But rarely do we see it demonstrated like we did during this pandemic. In New York, London, and in cities all across the world, major health systems that had once competed built systems to share knowledge and work together to manage scarce resources in real time. The health creating system we all want will not happen without real, built-in, hardwired, must-do collaboration. And such collaboration must be built into the economic foundations of those systems. This radical form of collaboration led to a realization about the 4th ingredient for building a better future. We learned during this pandemic that going slow is actually a choice. Whether we intend it or not, whether we are deliberate in our choices or not, we actually can and often do set the speed for change. We get to choose how fast we go. We get to call the meetings. We get to schedule the follow-ups. The old maxim proved true. When we found the will, we actually really did find new ways. And this applies to almost anything, from the way science is done to the way we vaccinate in a public health response. Slow is not a given. Slow is a choice. We get to choose how and when we want to accelerate to get to the system we all need and deserve. For Health Partners, change was not optional. Their cities demanded it, and the moment demanded it. Will was abundant. Crises have a way of focusing and motivating people, and the talented leadership of Health Partners knew exactly how to harness it. But I fear once the acute crisis passes, the chronic conditions will persist. And it is up to you, the leaders in healthcare, to create the will we need, to create the change that we need. Earlier this year, General Motors announced that they would no longer produce and sell petrol-powered vehicles by 2035. GM has dabbled in electric vehicles, but this decision by GM CEO Mary Barra, pictured here, was a watershed moment. And it was hailed by members of my country's new administration, who noted that it would accelerate plans to decarbonize America. The move by Ms. Barra and GM took courage, and that courage creates will. Soon after GM's announcement, many other leading automakers joined GM in plans to build electric vehicles and accelerate the end of gas-powered cars. Abandoning the combustion engine will be risky, but this is a time for a bold challenge to the status quo, to the way things have always been. So today I ask you, which of you will be the next leader to commit to and inspire change? Which of you will follow in the footsteps of the Japanese in the 1950s, the leaders that helped partners during the pandemic, the advocates and health professionals who helped bring down big tobacco, and the leader of General Motors? Which of you will design a better way forward for healthcare? Which of you will have the courage, ambition, and foresight to announce that the hospital as we have known it, a potent symbol of healthcare's chronic misunderstanding of what we need most, is a relic of the past? Our friends and colleagues in the UK have gotten the ball rolling. NHS England's ambitious long-term plan to create truly integrated care systems within the NHS recognizes existing trends and their intersections with what our societies truly need from healthcare. They found the will to change. They set bold aims, and those aims will create the strategies that we all need. I trust that this work will inspire others and inform efforts around the globe. It needs to. Converging forces of pandemic disease, racial reckoning, and climate change have unleashed an unrivaled combination of will for change across the globe and a torrent of exciting innovation. We may never have a moment like this again. Today, I ask each of you, in your home countries and in your home systems, to harness that will to change and to always work to create will in the future by demonstrating your courage. That courage and commitment, your courage and commitment, have animated IHI for all of its 30 years. We are with you, and today, at this pivotal moment, as we emerge, we need you more than ever. Thank you.